Hi, everyone. I have a very special guest with us here today, Dr. Peter Dzigielewski with UF Health. He's a board-certified otolaryngologist. He's also the director of head and neck surgical oncology and microvascular reconstructive surgery. In addition, he's also the fellowship director for advanced head and neck oncologic surgery at UF Health. A little bit about his training. He got his MD at the University of Alberta in Canada. He also completed his residency in otolaryngology there as well. And finally, fellowship in advanced head and neck oncologic surgery at The Ohio State University in Columbus, Ohio. First off, Dr. Dzigielewski, thank you so much for coming on and talking to us about your specialty.
My pleasure. Thank you very much for having me.
Sure. So getting started, if you could tell us, what is otolaryngology as a specialty and what does that entail?
So, otolaryngology head and neck surgery is a very diverse field. We are the surgical and medical specialists of everything above the collarbone except for the brain and eyes. We deal with a diverse group of patients all the way from birth to the end of life and everything else in between. And the modern otolaryngology head and neck surgery is really divided into a number of subspecialties as surgical and medical therapies have advanced, and that includes pediatric otolaryngology, otology and neurotology, or ear surgery, rhinology, which is more commonly known as sinus surgery, endoscopic skull-based surgery, which many people think of as brain surgery through the nose to get to the base of the brain, facial plastic and cosmetic surgery, facial reconstructive surgery, and sleep surgery, as well as trauma surgery, and of course my specialty, which is head and neck surgical oncology, or dealing with cancers of the head and neck and reconstructions that follow the surgeries.
I see. Gotcha. Yeah, I was wondering, so it's both a surgical and medical you can practice as either surgical or are there ENTs that do general ENT that's non-surgical?
Yes, and there's also what we now call comprehensive otolaryngology, or general otolaryngology, and that covers a little bit of all of the subspecialties that I mentioned, and that's much more common to see out in the community and private practice. But at academic centers, you'll see very subspecialized physicians, such as myself and my partners. And then you were mentioning as well the medical and surgical side. Most ENTs will have a medical side of their practice. A lot of what we deal with can be managed medically. And so your typical otolaryngologist out in the community who does general ENT will often operate once a week and have clinic 3 or 4 days a week. So the majority of the practice is actually medical in most situations. Now that varies by practice and by region, as well as personal interest. So if someone is more interested in an area that's more surgical, they may operate more. If someone's more interested in the medical side of things, they may have a larger medical practice. And a good example of that would be managing allergies. There are allergy specialists within ENT who have a large medical practice, and that's a possibility as well. So there's plenty of options and a variety of for almost anybody in our specialty.
I see. Very cool. So as far as residency, usually before your fellowship, I'm sure you do the surgical training within the residency, right? There's not
Yes,
anything like non-surgical ENT residency or anything like that.
not in North America. In North America, it's pretty much standardized between the US and Canada, where you will have 5 years of training, and the vast majority of it is surgical.
Okay.
Because as you can imagine, you can't learn surgery from a book or a video. You actually have to participate in it. So it's probably the most important thing to learn during residency. And so most residents spend the majority of their time doing surgery. But of course, they also spend an adequate amount of time in the clinic so that they learn how to work up patients and how to manage them before and after surgery.
Of course. Yeah, definitely makes sense. If you could expand a little bit on how many years of training to become an otolaryngologist, as well as the fellowship length.
So residency is 5 years, and during the first year, you spend about 6 months off service, And during those 6 months, you usually would do 1 month rotations in things such as general surgery, emergency medicine, neurosurgery, vascular surgery, maybe thoracic surgery, general medicine. There's a few different options. And then the other 4.5 years of your training will be in ENT. And a lot of it starts off with more basic medical management and inpatient management. And as you progress from 1 year to the next, you start to get more involved in surgery, starting from the most simple and working your way to the most complex.
Gotcha.
And following that, if you are interested in one particular area of otolaryngology more than others, you can do a fellowship. And most fellowships are 1 year. There are some that are 2 years. And some can be even longer if you want to incorporate research into those fellowships.
I see. One thing I'm very confused about is, can you go into general surgery residency and then choose to do ENT, or is it its own specific residency like neurology or dermatology?
That's a good question. There are some surgical specialties that go through general surgery, and ENT is not one of them. So if you want to do ENT, you go straight into it. That means some people start off in other specialties and then transfer into it, but that is not typical. Usually people start off straight ENT and finish in it.
Gotcha. Makes sense. Two questions. What drew you to medicine, as well as what drew you to otolaryngology specifically? Is that something you realized in med school, or the process of coming to that specialty?
Well, I think if I look back far enough as a kid, I was very interested in watching TV shows that involved surgery. For some reason, that really fascinated me, and that's what drew me into medicine. And then when I got into med school, I didn't know ENT existed, and I started exploring each surgical specialty through shadowing in my first couple of years. And towards the end of second year, I discovered ENT through our head and neck anatomy lab. And the first surgery I watched in ENT was a huge head and neck cancer resection, a total glossectomy with anterolateral thigh free flap reconstruction. And once I saw that, I was basically hooked. That was what really interested me. I loved the intricate anatomy. I loved the combination of science and art in the surgery, while at the same time being able to save someone's life and being able to follow that person along and get to know that patient really well over the course of time. I thought that was a combination of many different things that made the job very satisfying and rewarding. And I never looked back after that. Every time I thought about doing something else, it always came back to head and neck cancer surgery for me.
Awesome. No, I'm glad you found that. And yeah, the head and neck anatomy is always just so fascinating to me, even as a undergrad student. So that's awesome. And then what is the most rewarding part of your job?
I think there's a number of different rewarding parts, but I think firstly, the most rewarding part is taking care of patients with life-threatening illnesses, being able to save someone's life, and being able to give them excellent function afterwards in terms of speech and swallowing and quality of life. So in other words, to save them a life that's worth living, and then being able to see them long term and help them progress through their recovery. That is incredibly rewarding. When I see patients that I operated on 5 years ago or more, and now they're totally cancer free, I mean, that to me, that feels like a very rewarding, huge accomplishment. In addition to that, being part of an academic center, I train residents, and seeing how they do when they're out in their own practices, and hearing about the types of cases they do and the things that they're comfortable doing, and hearing about their outcomes is also incredibly rewarding to know that I could actually train someone and affect their life so that they could help others. So I think those are two of the most rewarding things about my job.
Gotcha. And what would you say is the most challenging part of your job?
Some of the most challenging parts of the job are the complicated operations that we do. Operating on patients who have had surgery before or have had other treatment like radiation therapy, and having to solve complicated problems of how am I going to remove a cancer and rebuild a defect. And so some of those surgeries can take 12 to 16 hours and require a lot of planning and a lot of patience to do. And those can be some of the most challenging days that we go through.
Gotcha. Yeah. And, throughout med school, you hear a lot about a surgeon's lifestyle and the hours, getting up early. So you're in an academic setting, of course, at UF here. If you could take us through just a brief typical day at work, the hours you wake up, if you're on call, that sort of thing.
That's a good question. And there's going to be a lot of variability in ENT depending on what your practice is like. If you were to go into a pure medical practice, you might just have your own office and you could set your own hours. You could work 9 to 5 if you wanted to and not be on call at all. If you are doing surgery, chances are you are going to have some call responsibilities. And so if I were to kind of give you the idea of what a general ENT may experience is you'd probably be starting your day somewhere between 7 and 8, depending whether you're operating. If you're operating, you might start a little earlier. If you're doing clinic, a little bit later. A typical OR day would end somewhere between 3 and 6, depending on how your hospital runs. And then you'd probably work about 5 days a week for the most part. Some people might do only 4 if they're out in private practice. And then on-call responsibilities depend on how big your group is. So if you're in a small group of 4 people, you might be on call 1 in 4. If you're in a big group of 20 people, you might be on call 1 in 20 days. I think the average is probably going to be 1 in 7 is typical for somebody who's a general otolaryngologist. And the call for ENT for the most part is not too terrible. Most things that we get called about can be managed the following day or the following week. There are some emergencies that have to be dealt with in the middle of the night, but that doesn't happen every single time you're on call. So most of the time you'll get a few calls. You can manage them over the phone, maybe once every couple of weeks, once a month. You might have to go in the middle of the night to deal with something. But it's not that you're expecting to go in every single time you're on call. Now, I mentioned the one end of the spectrum if you're doing medical ENT. The other end of the spectrum would be if you're doing head and neck surgical oncology. Your days are going to be longer. The surgeries are longer. Sometimes you have to make your days longer because you're dealing with cancer patients who can't necessarily wait. So instead of making someone wait a couple months for surgery, you may have to do it earlier and make your schedule busier. So you may be operating well past 6 o'clock on a regular OR day. And you may have more call responsibilities because you take care of more complicated patients. And so you may be in a smaller call pool to manage those patients. I'd say that, the spectrum on one end of medical ENT might be able to work 30 to 40 hours a week. On the other end of the spectrum in head and neck cancer surgery, you're probably looking at somewhere around 60 to 80 hours a week. And that would also include things like, we used to call it paperwork, and now it's all electronic, charting, phone calls, and all the other kind of communication related work.
Gotcha. Thank you for that. Very detailed answer. It gives me a very, very good idea of, the whole spectrum, because I'm sure, like you said, it varies with the different practice types.
Yes.
Going along with that theme of that variation, how do the cases vary depending on academic versus hospital versus private practice?
That's a great question. So let me give you a little overview of what types of cases you might be dealing with in ENT. The smallest types of cases might be putting in little tiny ear tubes into kids' ears, and that can take 5 minutes or less, sometimes longer if it's more complicated, but that's a very small operation. On the other end of the spectrum, you could be removing half of someone's face and rebuilding it with another part of their body, such as a bone in their leg. In between, you'll have smaller surgeries like correcting a crooked nose, maybe fixing someone's hearing by drilling the bone behind their ear, opening up their sinuses with cameras in their nose, facelift or eyelid tucks, decreasing the size of someone's back of their tongue so they can breathe better. Those are all kinds of examples of types of operations that you could do anywhere from a few minutes to a whole day's worth of surgery. Your typical ENT will probably do several cases in a day, ranging from something small to something as long as 2, 3, 4 hours long, like maybe a thyroidectomy or a parotidectomy. And so that's sort of the range of what types of surgeries you'd probably deal with as an ENT. Now, remind me, what was the other part of the question?
It was academic.
Yes. Okay. So in private practice, you're going to see a lot healthier patients, probably better insured patients as well, and that kind of goes hand in hand. So less complicated patients means your surgeries are probably going to be more routine. You'll be dealing with less challenges like operating in a really thick neck or a really scarred neck because they probably haven't been operated on before. So the surgeries will be much more textbook. In an academic center, you'll get more complicated patients, sicker patients, patients who may not have insurance, which often means also worse or more health disparities, worse medical problems that you deal with. You'll deal with complicated cases, patients who have had surgery done before and it's either failed or they need a revision operation, patients who have had radiation therapy before. So a lot of factors that can make the operation less textbook and much more complicated. So that's a big difference in academics versus private practice in how surgeries can vary.
I see. And I'm sure in academia, you're also a teacher as well, right? So you're teaching residents throughout your surgeries and your off time as well, doing admin work, right?
Exactly. So that can make your job can be a lot more stressful because you're in the process of trying to teach someone while keeping them safe. You want to be able to teach them to do the surgery without harming the patient as well, and that's a challenge in itself. And of course, residents aren't always consistent with you. So you have certain residents for rotations. So, right now I may have the same residents for 2 months, and then the next 2 months can be another set of residents. If you go out in a private practice, you might have a surgical assistant who works with you for years, and you just build and you have that consistency, and that can make your life way easier. So one of the challenges in academia is being able to competently and very well operate on a patient, but at the same time taking residents through cases and making sure that patient's outcome is going to be just as good as if you did it yourself.
Right. Yeah. It definitely sounds like a fine balance you have to maintain.
Absolutely.
How competitive is it to match into ENT?
ENT is one of the most competitive specialties to match into. In most years, I'll give you just a rough idea. Let's say we have 400 applications in the entire country. About 300 will get interviews out of those 400, and even less of those will match. And so there are often a lot of residents who are unmatched, and it's very uncommon to have unmatched spots at the end of the day. So it is very competitive. The applications are absolutely outstanding and get better and better every year. The USMLE or board scores are always very high. Applicants have some research on their applications. Some of the stellar ones have a lot of research. There'll be people on there who have been shadowing and doing elective rotations in ENT for a couple of years before they apply. They'll get reference letters from a number of different people that know them well. And so it is very competitive, but there are things that people who are interested in going into ENT can do to strengthen their application. Those who are interested often will approach a program and start working with some of the attendings to bolster that application.
Gotcha. Typical compensation for an ENT?
It's a good question. Now that will also range depending if you're in private practice or in academia. Starting salary for most ENTs, depending on part of the country, is going to be somewhere between $250 and $350 for somebody who's just starting out. And it can go all the way up into the seven figures if you're working in an underserved area, if you've been around for a long time, and you're more senior. Certain private practices may pay that much, or if you're running your own practice, you can potentially earn a lot more depending on how business savvy you are.
Gotcha. A common misconception about otolaryngology?
I think a common misconception is that it used to be referred to as easy nights in tennis. And that might be true if you don't have an operative practice, but I don't believe that there's a such thing as an easy operation or one that should be taken for granted. And so anytime you're doing a surgical intervention on someone, you are now introducing a complexity into your life that may have a lot of unexpected consequences. And so you should never take that responsibility lightly. So I do think that ENT is a lot more complicated than some outsiders might think it is.
Right. Yeah, definitely makes sense. A question that I kind of had last night when I was thinking about this interview, I scribe for a neurologist. So, I'm seeing Alzheimer's patients, and sometimes guys and girls my age who develop a resting tremor of the hand or of the neck, of the head. If you're in a surgical specialty, what happens in that case if you're an ENT? Are you able to switch practices and go more general ENT? Have you ever had a friend or a colleague who's been through that situation?
Yeah, I actually had a mentor back in med school who developed ALS at the end of his residency, actually. And he was in general surgery, and this would apply to ENT as well. And he had to completely give up his surgical practice and just became a surgical consultant.
Wow.
Now, in ENT, if for some reason, God forbid, something happened, you couldn't use your hands anymore, you could go into medical ENT. So that option still exists. So there is a backup in case of worst case scenario.
Gotcha. Yeah, no, it's heartbreaking when, when I hear about things like that because you've worked your whole life, gone through training, surgical residency, and to switch gears like that, it's definitely not an easy thing to do. But like you said, ENT does have that backup, and I guess general surgery might not have similar situations the way where they can do non-surgical, right?
I think in most surgical specialties, you could probably find some niche
Yeah.
where you don't operate and serve as a consultant. So you could potentially, maybe see patients and then help decide whether they need surgery and pass them along to a colleague who can manage them surgically, or you could potentially be involved in inpatient consults. There are creative ways that you could potentially get around that if disaster did strike. ENT just has a naturally built-in one that if you decided, I don't want to operate on it anymore, or maybe you're towards retirement, you say, I'm done operating, but I want to keep seeing patients, you have that option. You can keep going with medical ENT.
Right. No, that's awesome. That's great to hear. Even if, God forbid, nothing happens, you're still able to, I guess, close to retirement, you can switch to, general ENT and private practice or something like that.
Exactly.
Last question for you. What advice do you have for someone who wants to be a physician?
Well, I think the best advice I could give you is know what you're getting yourself into. I think a lot of people have an idea of what they think being a physician is, but it's not always accurate. Now, if you have any relatives or close family friends who are physicians, you might have a better idea of that. But if you don't have access to someone like that, I would suggest doing some shadowing. If you have um, um, a primary care physician, perhaps that you're close with, you could start by seeing if you can shadow them, or you could try cold calling a practice of some sort that you're interested in their specialty, and see if you can do some shadowing just to see what it's like and ask some questions of what getting into that specialty was like, what the training was like, what their life is like. You don't want to get so far into it that you're years into it and realize this is not the career for me. You really want to make that decision before you invest yourself into it, because it is a full investment. If you want to go into medical school and you want to be a physician, you really have to sacrifice a lot and really pour your entire effort and motivation into that.
Right. Absolutely. Yeah, I'm happy that med schools nowadays are a lot more holistic about it. They want you to have those clinical experiences beforehand. I know even 10 years ago, they didn't emphasize that too much. So I'm glad that changed. And yeah, so thank you so much for coming on and speaking to us. And I had a great time speaking with you. And I had a lot of questions about ENT and the surgical side of things, and definitely clear that up for me. And we really appreciate the time.
Great. Yeah. Thank you very much. My pleasure.